Hi and welcome to Lessons from the Grand Rounds. In this short video, we are going to discuss a case of BALL with CNS involvement, and we'll in general discuss about CNS involvement in acute lymphoblastic leukemias. So let's discuss with a clinical case. So a 45-year-old male recently diagnosed as a case of BALL after evaluation for pancytopenia on bone marrow aspirate flow cytometry. So this patient, the bone marrow aspirate sample was sent also for cytogenetics NGS and also for BCR, ABL qualitative PCR, which later turned out to be positive. This patient was started on UK-ALL protocol for induction, where he receives steroid in the first and the third week, and non-robicin and vincristine in 4 blocks. So this patient was in the protocol, even in the UKLL, in the COG, as you know, we perform 2 lumbar punctures where we send cytology, and we also give intrathecal methotrexate as a part of CNS prophylaxis. So we did a CSF for this patient on day 6 of admission, which showed 20 cells on the smear, on the chamber with 1 RBC. And there are atypical lymphoid cells with scant neoplasm, ovoid nuclei, and opened up chromadin. And this on the flow cytometry confirmed to be consistent with CNS involvement by BALL. So now this patient falls into the category of CNS3 status for BALL, and this patient receives 2 intrathecal therapies in the form of triple IT, where we gave him 12.5 mg methotrexate, 50 mg RRC, and 50 mg hydrocod as a part of triple intrathecal therapy. So the after 2 therapies, this patient was cytology was negative. So in general, there is incidence of CNS involvement at diagnosis for acute lymphoblastic leukemia in 5 to 11% patients. And what are the risk factors? So the risk factors involved, first is the high TLC. So more than 30,000 counts in TLC in BALL as compared to more than 1 lakh counts in TALL. The second risk factor is LDH being 3 times more than the upper limit of normal. Third risk factor is adverse cytogenetics, which involve 922 translocation and also translocation 411, which is MLL. And the fourth risk factor is T lineage. So T lineage in general at a higher risk of CNS involvement at diagnosis. So how do we treat this? So we perform triple intrathecal therapies, and we perform them twice weekly till we get 2 clear LPs, and then we perform LPs as per the protocol. So in general, patients receive approximately 15 to 60 lumbar punctures with intrathecal methotrexate over the course of therapy as per COG or UKLL. And my question for you guys is, what are the CNS directed therapies available in a case of BALL? Thank you.